It's time for us to discuss acute interstitial pneumonia. Acute interstitial pneumonia, also called AIP or Hamann-Rich syndrome, it was first described by Hamann and Rich in 1935. It is rare and fulminant IIP. As per the current ATS-ERS diagnostic criteria, AIP should include the following. Firstly, rapidly progressive clinical course that is less than or equal to 2 months leading to respiratory failure. Exclusion of known etiologies or any other known cause of ARDS, infectious, toxic or autoimmune pathology. Thirdly, diffuse alveolar damage on biopsy specimens. Radiologic findings consistent with ILD and absence of any chronic lung disorder. AIP is generally seen in previously healthy individuals with no prior lung disease. There's no sex predominance seen above 40 years of age. Patient presents with acute onset of fever, cough and rapidly progressive dyspnea. Many patients report having the sensation of infectious prodrome. The patients are mostly hypoxemic and rapidly progress to respiratory failure, even requiring mechanical ventilation. Signs of chronic lung disease such as clubbing are absent. Presence of skin or joint abnormalities might suggest an autoimmune underlying disease. Once cardiogenic pulmonary edema has been excluded, we have to search for other causes of ARDS. Medications and occupational hazards as well as rheumatological evaluation including serologic and muscle enzyme testing is important before stamping it as a case of AIP. Differential diagnosis essentially includes left heart failure, diffuse alveolar hemorrhage, organizing pneumonia, hypersensitivity pneumonitis, acute exacerbation of underlying ILD, and DIP. These can be distinguished from AIP by careful history, examination, radiology, and ancillary test. Once AIP has been established, underlying causes which needs to be evaluated and excluded are collagen vascular diseases, therapeutic exposure such as chemotherapeutic agents, biologic therapies, radiation, hyperoxia, use of illicit drugs like heroin, cocaine, toxic exposure such as smoke inhalation and other gases, history of any massive transfusion, any possibility of fat embolism, aspiration, and infections such as atypical pneumonia like mycoplasma or legionella and viral infection like influenza. Patients are generally too sick to undergo PFT. If done, it will reveal restrictive ventilator defect and impaired diffusion capacity. AIP is radiographically and pathologically indistinguishable from ARDS. In early exudative phase, we can see a lot of diffuse consolidation and ground glass opacities, mostly seen in dependent areas of lung being more affected. Differential diagnosis at this stage includes cardiogenic or non-cardiogenic pulmonary edema, diffuse infection or hemorrhage. In the late phase, that is chronic fibrotic phase, in addition to the lung consolidation, finding of underlying architectural distortion like fibrosis and traction bronchiectasis with or without honeycombing can be seen. It is generally more severe in the non-dependent portions of the lung. If the sputum culture is negative for any bacteria and viral studies are negative, we need to proceed with BAL to rule out any undiagnosed infection or whether there is any alternate diagnosis. There is no role of transbronchial biopsy in the diagnosis of AIP. So if lung biopsy has to be done, it has to be surgical lung biopsy. Diffuse alveolar damage, that is diffuse and extensive cell death accompanied by hyaline membranes, that is histologically apparent layers of fibrin mixed with necrotic epithelium. This material lines the alveolus and reflects the severity and acuity of the injury. As the injury progresses, it evolves into its organizing phase, which can either resolve into relatively normal lung or can result in lung fibrosis. In the inset A, we can see lung biopsy revealing edema, hyaline membrane and acute interstitial inflammation representing the exudative phase of diffuse alveolar damage. In the inset B, which was done at the autopsy. It showed interstitial and intra-alveolar fibroblast proliferation, which is the feature of the fibrotic phase. The worst thing about AIP is it is fulminant, often untreatable, carries high mortality. In like more than 50% of the patients die during hospitalization, and most patients die within 6 months of the diagnosis. Those who survive are at risk of disease recurrence or the development of other forms of fibrotic ILD. Supportive care in the form of supplemental oxygen or mechanical ventilation, adequate sedation, nutritional support, and prevention of ICU related complications such as prevention of stress induced ulcers, DVT prophylaxis, prevention of catheter related bloodstream infection, and VAP forms the basis of non-pharmacological treatment of AIP. The treatment for AIP is very disappointing. High or pulse dose glucocorticoid therapy is frequently administered to the patients. However, the data are conflicting for survival benefit. Expert opinion recommends continuation of this high dose steroid for several days, followed by a maintenance dose of 60 mg prednisolone per day that can be tapered over the coming weeks if the patient survives. In some scenario, when steroids are contraindicated or a steroid sparing agent is required, the clinician might try non-steroid based therapy like azathioprine, cyclosporin, cyclophosphamide, and vincristine. However, routine use is not recommended. OLT has been successfully done in several patients with respiratory failure attributed to AIP, but the data are very limited. So the take home points are: AIP is rare and fulminant. There's a rapidly progressive clinical course over a period of less than 2 months leading to respiratory failure. Exclusion of infectious, toxic, autoimmune or any other known cause of ARDS is essential. There's diffuse alveolar damage on biopsy specimens. The radiological findings are consistent with ILD. There's absence of chronic lung disease. High dose steroids for several days followed by a maintenance dose of the equivalent of prednisolone 60 mg per day followed by tapering is recommended. Thanks for watching the video.